Okay.
So we will start. Dear colleagues, dear friends, it's a pleasure for me to be with you today for this new webinar organized by the EANS skill-based section and dedicated today to the orbito-zygomatic approach, a very interesting approach that will be first anatomically described by Stéphane Liber working in Paris, and then the surgical aspect will be developed by Sébastien Fröhlich, who is also the head of department in Lariboisière Hospital in Paris. He will join us in a few minutes. So, Stéphane, I give you the floor, up to you to describe as nicely as you do every time the anatomical aspect related to this approach. Please, Stéphane. And thank you again to be with us. Every time you are with us, and it's a very hard work that you make for the skill-based section. Thank you so much.
Well, thank you very much in any case for having me. It's, well, a bit of work to prepare this, but it's a pleasure, and it's always good to revise those things and putting it together. Can you see my screen okay?
Yes, perfect.
Perfect, all right. So today we'll be talking about the orbito-zygomatic approach, or the frontal orbito-zygomatic approach, which is an extension of the pterional approach, one of the approaches of the anterolateral corridor. This is an approach which extends the frontoterional or frontotemporal corridor inferiorly and creates space by removing some of the bone of the supralateral orbit and the temporal floor, which changes angles for the intracranial work, but also allows access to the orbit and also to the extracranial space of the pterygopalatine fossa, the infratemporal fossa pathologies extending from the intracranial to the extracranial space. So this is a one-piece FTOZ, or a one-piece frontal orbito-zygomatic craniotomy, which again is centered around it's the extension of the pterional approach. And you see all the bony landmarks of the pterional approach here in this craniotomy, plus the frontolateral part of the orbit and the zygomatic arch, which has been removed here. You can see the orbit, which is opened in its lateral and superior aspect. You can see also the extension into the extracranial space. We'll come back to this later. What you also recognize in this picture is the trajectory you see here in the level of the floor of the middle fossa. You can see the petrous apex, you can see the dorsum sellae. In fact, one of the first historic description of this approach by Hakuba is in fact done for clipping for microsurgical control of petrous apex basilar apex aneurysm, which is this region, and you can see all the extensions feasible for this approach, and also reducing, obviously this is a main goal in Scave surgery, one of the main strategies, reducing mobilization and traction and retraction of intra or extradural brain tissue. This is all of this in this talk will, as in previous talks, will be purely anatomy. It's not meant to be a surgical description of indication and technical nuances. It's just to give you, the audience, an idea of the anatomy. Some of the anatomy, obviously, in anatomy can be destructive in order to better understand and to depict the anatomy for better understanding of the surgical approach, which is in masterly hands in the second talk by Professor Fröhlich in 20 minutes, I guess. So this again is a one-piece FTOZ. You see the extension of the pterional approach, removal of the superolateral part of the orbit, extension into the anterior fossa, removal of the zygomatic arch, and you see the extensive mobilization of soft tissues, which is necessary for this approach. We'll come back to this later. And as I said, this is an approach, an extension of the terional or frontotemporal parietal approach, which is centered around the Sylvian fissure, which exposes frontal lobe, temporal lobe, insular Sylvian fissure. And the FTSE with its basal exposure allows a more anterior trajectory, as I said, for example, towards the posterior clinoid, and the posterior fossa also into the orbit pathology, extending into the infratemporal fossa, pterygopalatine fossa, or any pathology that might combine all these compartments. This is a view, just very little into dural anatomy in this talk. This is a Stepwise webinar just for you you're familiarized with this view, the right side of the chiasma, lamina terminalis, anterior, middle, and terminal carotid here, the SCA and PCA, third nerve in between, fourth nerve running towards the tent anteriorly. This is a perspective which is feasible with a mini terional or just a smaller variant. And this is one of the extension, again, this is an anatomical dissection without with the brain itself removed, just to give you an impression of the more posterior, antero-posterior trajectory of this, of the tent oculomotor system. Here, the oculomotor nerve exiting from the interpeduncular system. You have the PCA, SCA, dorsal clinoid, dorsum celli here. This is the region which, as I said, was originally described by Hakuba in one of his first description of this extension. Unfortunately for us, and also sometimes for the patient, surgery doesn't start here with this nice exposure. We have to get to this point. And this requires, as I said, control of the extracranial tissues, which is extensive. We have the pericranium elevated here. We have the skin removed anteriorly. We have complete control of the temporalis muscle, which is elevated and mobilized more laterally. And of course, in this cutaneous flap, we have the facial nerve, vascular supply, nervous supply for both the skin and the muscle. All this needs to be controlled. And I will briefly cover this in this slide. As you see the anatomy here, this is tragus temporal artery, and the superior aspect of the parotid gland, where the facial nerve exits. These are running to the frontoparietal muscle, but anatomically correct. These are temporal branches ascending towards the perium, the orbicularis oculi, and the frontoparietal muscle. And these are obviously running in the fat pad, which has been dissected here. This is just to give you an orientation of tragus, zygomatic arch, temporal artery, facial nerve branches, and the lateral canthus, which is here. And you see this surgical depiction. I will not cover surgical details of extensive mobilization, placement of incisions, and so forth. But usually you need to connect your inferior incision, which is usually at the level, since we are mobilizing the zygomatic arch, needs to be mobilized at least towards the level of the zygoma. And you need to control lateral or a midline, mid-pupillary line incision to have mobilization of these soft tissues. This incision probably is already a bit too anterior for me. If you incise just in front of the cartilage of the tragus, usually you end up posterior to the temporal artery, not medial to the temporal artery, which in many cases can be, at least one branch can be preserved. That's the point of this incision. This talk is the third in a mini series on the anterolateral corridor. I've done. It was a great pleasure to prepare 2 talks already on the terional approach, which are used to explain a bit the extracranial tissue and the anterior clinoidectomy. So some parts I will briefly repeat, because obviously they are part of this approach and important to know. Some of them are covered in more detail in these 2 webinars from January and February. Obviously, in January we talked about histology, the soft tissues, facial nerve, fat pad, interfacial dissection, muscle preservation, all these things. This was purely based on extracranial anatomy, which is the basis for all these approaches, and will also be the base, I think, for an upcoming webinar. The next one, I think, is on mobilization of the lateral wall, peeling of the middle fossa, and anterior petrosectomy. This is all essentially the same approach with variation here towards pathology or extensive extension of the pathology addressed. And the second one on anterior clinoidectomy was again an anatomical dissection of the roof of the cavernous sinus, acubus and Dolenk's triangles, transition of cavernous sinus structures into the orbit, so description of the superior orbital fissure, and mobilization of the mobilization and the dura of the middle fossa via incision of the orbito-temporal periosteal fold. All this was part of these two webinars, and I will just briefly show some pictures for those who have not seen this to go back for these for this animation. This is a depiction of the, as I said, the temporal branches of the facial nerve that ascend towards the the frontal parietal muscle and the orbicularis oculi. Here, this is the temporal artery. This is a very nice paper, which I will not explain in detail now, which was part of this January webinar, which very nicely depicts and explains the development lateral, medial lateral to the superior temporal line, the attachment of the temporalis muscle of the pericranium, and the layers of the superficial and deep temporal fascia layers, which engulf the fat pad and the facial nerve. This is essentially relevant anatomy and functional anatomy for the interfacial dissection. This again, just briefly to revise, there's many techniques. This techniques we are using here, which brings you in this dissection plane of the profound temporalis fascia right towards the zygomatic arch, which needs to be exposed and mobilized. This is again an anatomical of technical importance in this approach. Mobilization of the temporalis muscle, as I said, we are exposing not only the entire muscle here, we are mobilizing the muscle or the attachment of the superficial part to the posterior aspect of the zygomatic arch, and also extensively mobilizing for the cuts into the superlateral orbit and the inferior orbital fissure. We're mobilizing the extensive the muscle in its totality. This again is the functional and anatomical basis for the preservation of muscle, which is not only blood supply, but also nervous supply. This is the basis for all these approaches. Retrograde dissection, as described by Oikawa Oikawa and its established technique. This was part of the webinar. Today, I will be talking about the special osteology of the FTOZ approach, or the orbito-zygomatic approach, the Mccarthys burr, which is a relevant burr in accessing frontal and orbital, and exposing frontal and orbital dura at the same time. I decided not to cover pneumatization of the frontal sinus because I think nowadays more or less everyone is using navigation. Pneumatization is an issue in these skull-base approaches, not only for the frontal sinus, but also for the root of the zygomatic arch, for the proximity of the maxillary sinus once you do the inferior cut, and needs to be controlled and addressed in any case. And also there's no landmark, there's no guidance. There used to be the rule that there's no pneumatized frontal sinus lateral to the supratrochlear and supraorbital nerve, which is certainly not true. So in any case, I think it needs revision of CT and MRI imaging before surgery, and needs to be addressed also with navigation during surgery. Briefly, I will be talking about inferior orbital fissure, Müller muscle, which closes the inferior orbital fissure, which is probably more familiar for those of you who do endoscopic approaches. Then briefly, because in my last talk about anterior clinoidectomy, we covered roof of the cavernous sinus. Really briefly, I will be covering some of the lateral wall and again the orbital apex, since we're talking also about intraorbital surgery. The extension into the middle cranial, into the extracranial, extradural structures as pterygopalatine fossa or infratemporal fossa, extending, so pathology extending through the bone via the anteromedial and anterolateral triangles. This is something that has been published extensively by Professor in a few years ago. Very interesting concept for these extradural approaches. And then briefly, because again, we're talking about orbit, some of the orbital intraconal space and orbital muscles. Also to understand the position of these structures, to avoid complication, just to point out these structures, because it is also an experience intense. It's a more extensive approach. It needs to be well controlled and still carries some sort of morbidity, which can be minimized addressing all these techniques, as I said, facial nerve, muscle, and also avoiding orbital complications. So some bony anatomy. We're talking about the junction of the frontal bone, the toroidal bone, the temporal bone, with the zygomatic process, which forms the zygomatic arch. This is the zygomatic process of the temporal bone, the squama of the temporal bone. This is the temporal extension of the zygomatic bone. This is the junction between maxilla and zygomatic bone near of the greater wing of the sphenoid. And obviously, this is your familiar landmark of the pterion, which is the most lateral extension of the greater sphenoid wing, with anterior fossa and middle fossa. And you have the orbital or frontal process of the zygoma and the zygomatic or orbital process of the frontal bone joining here to form the superlateral orbital rim. Again, these are the sutures forming the pterion, which is in a rather ill-defined point, which accesses, as I said, frontal and middle fossa. And we are talking about Mccarthys keyhole, which is situated normally right onto the frontal sphenoidal fissure between frontal and greater sphenoid wing. Here, just roughly a centimeter behind the zygomatic or sphenoidal fissure, which is just here which is not shown in this picture. I couldn't find a picture with just a skull showing this. We'll see it later when in a surgical dissection when we have the muscle removed. So this is the position of Mccarthys keyhole, which we'll discuss later. And this is the region of the pterion. Obviously, you have the junction between temporal process, zygomatic process of the temporal bone and temporal process of the zygomatic bone here, greater sphenoid wing, all these structures of the skull base. We've seen this before, just again, middle fossa, lesser wing and greater wing of the sphenoid. We have the region of the pterion, which gives you access to the anterior fossa and the middle fossa. And in contrast to this, Mccarthy in the 60s described this bubble, which is a bit more anterior in position, as I said, right onto this frontal sphenoidal and frontal zygomatics, just a centimeter behind the frontal zygomatic suture, which exposes the dura of the frontal of the interior cranial fossa, which is frontal dura and the periorbit. Again, this is depicted here. You can see the region of the pterion from the inside on this side, and from the outside here, you have the junction of greater wing and frontal bone. This is the region of the pterion, and the region of the Mccarthy beehole would be here, which brings you right into the interior fossa, but also in the orbit. I will take you stepwise. Again, this is not a surgical description. This is just an anatomical primer for all these approaches. I will take you through this approach. As you see, this is a one-piece dissection, taking off the superlateral part of the orbit, opening the roof of the orbit, opening the lateral aspect of the orbit, entering briefly here. This is inferior orbital fissure, also the space in through the intratemporal fossa. Ptericopalatine fossa could be here, could be accessed as well. The drilling of the anteromedial and anterolateral triangles. This is the bony exposure that can be gained with this approach. Obviously, the extensive, the degree of the size of the pterional parietal extension of this craniotomy needs to be addressed. Just for those who are interested, I always find this very interesting. Just going back to the original descriptions of these approaches. These are just 3 or 4 references I put together with some of the pictures. As I said, Taguba, I think half of this series is basilar apex aneurysms and posterior clinoidectomy to address the petrous apex via this basal exposure, which is again opening of the inferior orbital fissure, cutting the zygomatic arch and the superior lateral aspect of the orbit. This is again one of the original pictures in this paper with the muscle still attached to the craniotomy, which is a different, I think nowadays, an ancient technique. This is a very nice paper just a few years later, 1990, which I very much like because it has a lot of intraorbital dissections and descriptions, which is obviously also an indication for this or an extension of the surgery. This is just to give you an impression of some of the literature. This is a more recent technical description, a very nicely illustrated technical description, which is very close to what we do here in Paris, which is a cut in the roof, and a burr hole on the superior temporal line, or depending on how extensive the approach needs to be. Another one at the level of the root of the zygoma, and then the cuts, as we will see, towards the disconnecting the root of the zygoma, malar eminence here, disconnecting the supraorbital rim here, the frontal part, and here the zygomatic part, and disconnecting it from the zygoma. And this is the frontal zygomatic suture between maxillary and spinous, which is not part of this craniotomy. This is a stepwise. Now this is a one-piece stepwise anatomical description. Again, this is not real surgery, just to show you the landmarks as we described. This is the region of the terion. This is the superior temporal line. This is the squama temporalis, temporal process, and zygomatic process, which form the zygomatic arch. This is a burr hole just slightly anterior to the root of the zygoma. This is the cut which disconnects the zygomatic arch. This is the cut into the inferior orbital fissure, which disconnects the inferior aspect of the craniotomy. Then there's another aspect of this keyhole which cannot be seen. This is the opening of the orbit, which is here. So this is a Mccarthys burr hole, which is, as I said, situated in the frontal sphenoidal suture and just slightly posterior to the frontal zygomatic suture here, also behind inferior and covered by muscle in this aspect here. This again is purely anatomy. You see the arch, which has been cut posteriorly, which has been disconnected from the malar eminence. What's missing in this, obviously, this is inferior orbital fissure, this is superior orbital fissure, is the cut through the sphenoid wing, which disconnects the last bit of the craniotomy, which we've seen in probably one of the surgical videos of Sebastian Fröhlich later today. Briefly, to understand not only the anatomy, but also some potential complications or aspects that needs to be guarded during this surgery. We have the superior and inferior orbital fissure, the optic strut and the maxillary strut separating the two. We have all the nerves running, the optic nerve obviously not, and the ophthalmic artery obviously not, but all the nerves entering the orbit from the cavernous sinus. So this is the organization of the orbital apex, and both superior and inferior orbital fissure are organized in a lateral, a medial, and a lateral middle and a medial compartment. And then you have the extension here into the infraorbital nerve and groove towards the infraorbital foramen, which actually can be seen here. I covered this orbital apex. I covered this in the recent talk about clinoidectomy, obviously, to understand which nerves are at risk once you do a clinoid, which sits in this position. This is also important for control of the orbit. I put this image in to show you the Müller muscle, which is this here. This is inferior rectus muscle. This is oculomotor nerve with a ciliary ganglion, inferior and superior branch. This is abducens nerve, so this is a right side lateral perspective. But you can very nicely see this muscle, which is it's a remnant in humans, a remnant which closes like fibrous tissue, the inferior orbital fissure, which is partially exposed once you dissect orbit from the outside to mobilize to deconnect periorbit and expose the inferior orbital fissure for the last cut. This is again anatomy, but purely stepwise dissection just to show you some of the aspects. This is a one-piece FTOZ now. We see again a keyhole, which is on the frontal sphenoidal fissure behind the frontal zygomatic fissure. Here, this is exposed dura of the periorbit. You would see from a different angle, you would see frontal dura here. This is the cuff, which is a technical variation. You can use small boreholes also to reconnect the muscle. This is a borehole towards the root of the zygoma and the mobilized muscle, which is here. You can see zygomatic or foramen of the lateral orbit. Again, this is the one-piece FTOZ, a zygomatic arch. Disconnected from the malar eminence, the lateral and superior aspect of the orbit. You see the supraorbital foramen or notch exposed here, needs to be controlled in surgery, needs to be drilled or controlled, elevated with the pericranium to reserve the nerve, and then your standard craniotomy towards the posterior aspect. This is one of the few intraorbitals pictures. Just to give you an idea, this is access to the orbit, obviously access to sylvian fissure, frontal and temporal, or the cysternal space, more posterior trajectory towards, as I said, towards posterior fossa, also petrous apex, drilling of the posterior clinoids, anterior clinoidectomy towards the orbit, and the floor could be extended towards extracranial pathologies. This is a two-piece FTOZ. There's no rule or no reason for the numbers of pieces. Maybe Professor Fröhlich will comment on this later. This is there's probably just the rule that it should be minimal mobilization and or traumatic for the structures removed. If there's hyperostotic bone or an infiltrative bone, it probably is not reasonable to do a craniotomy in one piece. This depends on preference, pathology at rest, and surgical experience. This is just an example of a two-piece FTOZ. Again, in real life, this is more or less the same, with the exception that the supralateral roof and the cut of the zygoma is separate in this case. And this is, again, as I said, we have periorbit exposed here, the supraorbital nerve exposed here. The dura around the sylvian fissure is exposed, and the number of pieces in which you cut your craniotomies is not relevant as long as you put it together correctly. As I said, we will be having another webinar on peeling of the middle fossa floor, addressing petrous apex, anterior petrosectomy. I will only briefly, last time I covered some of Doleng's and Hakuba's triangles of the superior roof when we talked about anterior clinoidectomy. Just briefly, some of the lateral wall. I will not go into detail of the described triangles, Mullins, and all of these triangles. I think this is obsolete. Just historically, it's interesting. This is exposed of the lateral wall. Again, this is the right side. You see the oculomotor triangle, which is entering in its system via the roof. You have the fourth nerve exiting the tent, and also the transition entering the cavernous sinus, the transition of roof and lateral wall. And you have Mccarthys cave with the ganglion, V1, V2, and superior orbital fissure around foramen, overlap foramen, and middle meningeal artery. I show this partially. This is essentially the same, exposing sixth nerve, which runs in the middle of right into the cavernous sinus. I show this partially to just to explain this maximal. Again, this is an anatomical dissection, but it shows you the relationship of this approach, where you can actually enter sphenoid sinus, you can go into the pterygopalatine fossa, you can go into the orbit, and control orbital apex, intracoronal pathology, you can follow meningioma or schwannoma extending into the infratemporal fossa, and all other pathologies that might combine both extracranial and intracranial, intradural or extradural compartments. This can be geared towards the pathology and allows for an extensive approach if, as in this case, the pterygoid and the interior part of the middle fossa is drilled completely via the anteromedial and anterolateral triangles as seen in this example. This is essentially the same, just to focus on the orbital apex. You have the sphenoid sinus here. You see, again, the V2 and the pterygopalatine fossa, branches of the maxillary artery, intraorbital artery exiting here. You see, in this case, you don't see Miller muscle. You've seen Miller muscle before. This is the inferior rectus and ciliary ganglion, all the structures intraconally, which I will be showing in a moment. I wanted to show a bit, both in order to explain some of the intraorbital structures to avoid complications, because I think the most serious and the most frequent complications of this approach probably are still the intraorbital complication once periorbit is mobilized, if there's compression or if there's trauma or transgression of the periorbit, but also because obviously this approach can be used to address intraconal pathology of the superior lateral compartments of the orbit, or pathology of the optic nerve, or pathology of the orbital apex. This is the anatomy you don't see in the FTOZ approach. This is the anatomy from the outside, just to explain that there is an orbital septum which closes the orbit anteriorly. You have the pericranium, which extends in the orbit, which forms the orbit. You have the attachment of the lateral-canthus, which is Withnell's ligament, which has a bony correlate here, just inferior to the frontal zygomatic suture here. You have an intraconal and an extraconal part of the lacrimal gland, which sits here superlaterally in the lacrimal fossa. This normally you would not see this in your elevation of the periorbit, but it needs to be known, and also it's important to know that usually the connection of the attachment of essentially all these structures with Withnell's ligament and the attachment here towards the bone are mobilized once you peel and medialize the periorbit in order to expose your inferior orbital fissure in the orbit. So this is the bony structure I talked about. This is the bony correlate of the fibrous attachment of Withnell's ligament, which forms the lateral canthus and the apparatus of the lid. All the intraorbital structures, pericranium, periorbit, fat, all this has been removed. But this dissection, this is also one of the reasons why I include this, has been done. And this within FTOZ, you can see the frontal cut, you can see the cut through the zygomatic bone, you can see the burr, the lateral cut inferior to the orbit, disconnecting the orbital rim, and understanding the orientation of the muscles within the orbit. You see the hypoglochleon of the superior oblique. You see the superior rectus, lateral rectus, inferior oblique, inferior rectus, which runs here. So all these structures exposed. Also supraorbital nerve, supratrochlear nerve in the superior medial quadrant of the orbit, which is in any case the medial margin for the bony cut. A more lateral perspective, again, this is superior levator and superior rectus. You have the superior oblique, medial rectus, inferior rectus, lateral rectus. This is again the keyhole which corresponds to the Mccarthys keyhole. Here you can very nicely see the lateral rectus muscle, also remnants of Müller muscle, which is again, this is the region of the cut towards the originating from the inferior orbital fissure, and you see the intraorbital nerve, which exits here by the infraorbital foramen, and same for the supraorbital foramen and supratrochlear nerves, which run in the supramedial aspect of the orbit. Very briefly, just to orient you within the orbit, this is a superior aspect of a right orbit. You can see the medial rectus. You can see the sensitive ophthalmic supratrochlear and supraorbital nerve, which runs here. This is the lacrimal nerve, which has been cut. Lacrimal gland has been removed, sits here. This is the levator palpebralis superior elevator, and underneath the superior rectus. And these are the the spaces that can be used to address interconal pathologies, optic nerve gliomas, hemangioblastomas, whatever resides in the orbit needs to be addressed with this approach. Again, this is superior oblique nerve, which with the transition in the supramedial aspect of the orbit. This is the superior rectus mobilized and cut to expose the optic nerve, ciliary artery, and all the vasculature, ciliary ganglion of the retroorbital space. This is ciliary ganglion. You have the lateral rectus here, inferior rectus, lateral rectus abducens nerve. Here has been cut to open. This is abducens nerve. You have the superior and inferior trunks of the oculomotor nerve with the ciliary ganglion. This is intraconal anatomy, and again Müller muscle closing the orbit towards the intratemporal fossa, closing the space of the inferior orbital fissure, and these are intraorbital nerves V2 running towards the intraorbital foramen. This was just a brief overview of all this anatomy that can be addressed. As usual, I think all my mentors in anatomy and in surgery here, Sebastian Fröhlich in Paris and Juan Fernandez Miranda, where I did all this work in Pittsburgh at the time. Thank you very much.
Thank you so much, Stefan, for this outstanding lecture. As usual, you show very nicely the anatomy. It was very interesting to see the intraorbital anatomy as well, to remember it and to discuss the different complications. I have just one question on a practical point of view, just to know, I'm thinking everybody will be interested with that. How long does it take for you to prepare such images? Those are amazing, and I expect a lot of hours and even weeks to prepare such image.
Yeah, orbit takes very long because orbit is also difficult to photograph. I don't know whether you have seen this small metal pins. Yeah. Because you lose all the volume once you remove the fat. You lose all the volume, and yeah, you have to dress your specimen once you're done with the dissection. Also, dissection takes long, and you have to take care that it's not getting dry, that it doesn't change color. There's all these tiny aspects. It takes, yeah, orbit is difficult to dissect. It takes long. Yeah.
So impressive. So now, Sébastien, you arrive with us after your surgery, and we have now seen the standard orbito-zygomatic approach, but probably you will discuss also with us the way the approach has to be tailored according to the pathology that has to be reached. So please, I give you the floor.
Thank you, Michael. Sorry for being late today, but you had a great lecture from Stefan. So let me share my screen. Yes. Yes, so I will focus on the technical aspect of the FTOZ approach and on some tips and tricks of the technique I am using, which is a one-piece FTOZ approach. So a lot of what I am going to say has been said already by Stefan, but it will be a little bit of repetition for some of it, which is always good. So about the indication for the FTOZ approach, definitely the indications are more limited than before. When I started neurosurgery and my fellowship in the US, it was something that we were doing quite commonly for deep-seated lesion, in which we wanted to avoid retraction of the brain. And it was not yet the time of keyhole surgery. It was the beginning of it, but definitely with keyhole surgery, there is still a trend towards less aggressive approach. So we are using it less than before, but still there is some good indication for FTOZ approach, which is an extremely important skull-based approach with the most important concept of skull-based surgery with it, which is we can do a lot of bony work in order to avoid brain retraction. And at the end, the cost of bony work is always less than the cost of injuries to the brain. And this is why we are neurosurgeons. So as you can see on this slide, there is a trend towards orbito-frontal, orbito-pterional, lateral supraorbital, mini-pterional, but also keyhole approach for sometimes lesions that we were treating with an FTOZ. So here in pink, you have the big FTOZ, in green, you have the subfrontal approach, but still there is room for both, and it's something we use in Paris in my team. I use quite often keyhole approach. I use sometimes FTOZ. It gives different advantages, and it's made for different type of lesion. With the keyhole approach, you have one entry point, and you can browse quite a wide area of the anterior skull base and also of the middle skull base. But the entry point is in the same area. It's a single entry point. With the FTOZ, you can have very multiple line of sight. As you can see on this slide, you can look at the tumor from different perspectives, which is great for some tumors with critical structure around, for which with a keyhole approach, you don't necessarily have the good line of sight to see what you are doing. So again, the goal of those approaches is to protect the brain. And if you feel that with an FTOZ, you will have less retraction, less lesion to the brain, to the cranial nerve, then it's a good option. What makes the exposure is not only bone, and I have seen several times colleagues, fellows focusing on the bony work and forgetting the soft tissue part of the approach. To expose the bone, you need to have a proper soft tissue dissection. On the soft tissue dissection, the soft tissue elevation should not obscure, should not be in the way of the line of sight that will be given by the bony work. Otherwise, the bony work you have done is for nothing. So it's extremely important, most important, to have a proper soft tissue dissection, and then the bony work, the bone flap, the drilling, according to the exposure you got with the soft tissue. So what does it give? It gives a wide exposure of the skull base. You get closer from the critical structure. With a keyhole approach, you are quite far from the critical structure. If you need to turn around a tumor with critical structure around, it's nice to have a shorter distance, and the FTOZ approach is made for this. You also have a lower line of sight. You can look at the inferior surface of the frontal lobe from below, and you can have a fantastic exposure of the cavernous sinus, orbital apex, supraorbital fissure, caverno-orbital junction without any brain retraction. For a tumor like this, it's a case I've done quite a long time ago, but I think it would come again today. I would do it the same way. It's a metastasis, single met of a patient that was getting blind, young patient. We wanted to reduce the mass effect of this tumor before radiation therapy. And you can see the optic nerve, optic chiasma around this tumor. It's better to come from below in a case like this. I didn't want it to come endoscopic because it's a met and it's bleeding a lot. And it's a small tumor, but for which FTOZ, I think, has some advantages. One of my main indication, concept I am using for FTOZ now is the orbito-temporalis muscle corridor, which means that it's not really the superior orbital rim that give me an advantage. It's more the lateral aspect of the superior rim and the lateral rim of the orbit that is good to remove with the FTOZ. Why? Because you have this oblique line of sight coming from anterior to posterior, lateral to medial, inferior to superior, looking at the inferior surface of the frontal lobe. And you know that the superior wall of the orbit is bulging a little bit superiorly. So removing the superior aspect, the superior orbital rim, in fact, doesn't necessarily give you much in terms of lower line of sight. But this more lateral line of sight, given by the removal of the lateral orbital rim, is really nice. And this is one of my main indications for FTOZ now. How do you get to this line of sight? With the FTOZ, you expose the orbit, obviously, and you push the temporalis muscle inferiorly and laterally, and you create a corridor like this with this blue line between the orbit, between the retracted temporalis muscle to look at the inferior surface of the frontal lobe. Fantastic exposure, for example, giant clinoidal meningioma. This is a dissection of it. You see here that this line is not going through the superior rim, but it's really going through the lateral rim and a little bit using the corridor of the body of the maxilla. And you can see here that looking through this line of sight, you really have a view of the inferior aspect of the frontal lobe. If you have a tumor inside, you can look at this tumor without any retraction of the frontal lobe. This is, I think, a CT scan of Rosaria Abriti specimen dissection. She's one of my colleagues, and she did a work on this with some measurements. And this is exactly here the corridor in red that you gain with this FTOZ, retraction of the temporalis muscle inferiorly and posteriorly, and removal of the lateral rim. This is an example of it where we use the neuronavigation, and you see that the probe is really passing between the orbit, between the temporalis muscle, and there is zero retraction before we get to the tumor base of this tumor. And you see how deep is this tumor, surrounded completely by the frontal lobe. So to avoid brain retraction, it's the only way to go with this FTOZ on removal of the lateral rim of the orbit. This was the case. The epicenter of a lesion like this is really the anterior clinoid process. You can see here all the feeders. It was quite a bloody tumor with a big blush. So again, getting to the tumor base without any retraction or limited retraction first is definitely an advantage. And this was a post-op MRI of this patient with, I would say, no injury of the parenchyma. This was another case where FTOZ to me is great. If you use a classic frontotemporal approach, you really need to open widely the sylvian fissure. Still, you have edema of the frontal lobe, who is quite fragile at the end of the surgery. Extremely difficult not to have some injury of the parenchyma, frontal lobe, temporal lobe. We are on the right side. I would say it's acceptable, but on the left side, it could be definitely an issue. With the FTOZ approach, with this lateral rim of the orbit removal, this corridor between orbit and temporalis muscle that we use, we have an access to the tumor base. We can debulk first without any retraction of the brain. This is a case, a series that is in preparation, showing some tumors like this, where we used FTOZ approach. For those tumors, you can see that it's a significant size tumor for most of it. So extent of resection with this approach is quite good. It's not 100%, but 75% of gross total resection or near total resection, and no complication in terms of brain injury. Another advantage of the FTOZ approach is that it gives you a wide exposure of the skull base, give you a wide exposure of the orbit, caverno-orbital junction, but also of the temporal fossa floor. Once you have retracted the temporalis muscle very low because you remove the zygoma, so you can really retract more the temporalis muscle, which is kind of a door that open to expose the floor of the temporal fossa, especially the anterior aspect of the temporal fossa floor. This was a case where we used this approach for resection of this adenoid cystic carcinoma, where we did a cavernous sinus exenteration. So for a tumor like this, if you want to do oncological resection, which is questionable for adenoid cystic carcinoma, I agree. But here we wanted to try to give a chance to this patient, and FTOZ was perfect for this because you have a superior exposure of all the part of the tumor. Let me see something. I am missing few slides. I'm sorry. No. I'm sorry, I was confused. So one of the structure, I will go now in the step-by-step technique of the FTOZ as I do it myself in the OR. One of the critical structure to protect during the soft tissue dissection is the frontal branch of the fascial nerve. I'm sure Stefan showed you some of his pictures. This is one of his pictures, I believe, where you can see all the bundles of the fascial nerve. This is running in the subcutaneous tissue, and it has to be protected with a proper technique. So this is the bony anatomy. I will not go over this again. This is a classic incision for a frontotemporal approach. If you want to do an FTOZ, you have to make a bigger incision, because if you draw a line between the two extremities of this classic frontotemporal incision, and you cannot expose here the body of the zygoma, lateral rim of the orbiter, superior rim. If you want to expose the bone anteriorly, you need either to go lower at the level of the tragus, in front of the tragus, or you have to go on the opposite side. The two extremities, the lines that join the two extremities, need to go through at least this posterior aspect here of the body of the zygoma. Otherwise, you will have a very hard time to expose the bone, and you will need a huge amount of retraction, which is not good for the soft tissue. So if you want to extend your incision inferiorly, you can do it, but you have to do it as posterior as possible along the tragus. Because if you are too anterior, 1 centimeter in front of the tragus, quite rapidly below the level of the zygoma, you will get close to the frontal branch, the most superior branch of the frontal branches of the fascial nerve. Usually you don't cut it, but you can easily injure it when you try to coagulate some venous bleeding or arterial bleeding in this area when you extend the incision down. So the more posterior you are, the best it is, and you can go almost 1 centimeter below the level of the zygoma without much risk of injury to the frontal branch. And it allows you to retract the skin more anteriorly and to expose the bone. Once you have elevated the skin flap, you elevate the periostom here. Classic way, I think we all do that. It's always good in skull-base surgery to have this tissue intact, to be able to replace the dura post-op if needed. Then you need to separate the skin flap from the temporalis muscle, because we will retract the skin flap anteriorly, the temporalis muscle posteriorly, and we have to expose here the lateral rim of the orbit. So in order to do that without injury to the frontal branch, we need to do either an interfacial dissection in red or a subfacial dissection in black, because the frontal branch is here into the subcutaneous tissue. So we need to go at least below the superficial temporalis fascia here. So either with interfacial or deeper with subfacial dissection. I personally prefer the interfacial dissection. How I do it? I make an incision here of the tissue along the superior temporal line. I tract here with a pincette the superficial temporalis fascia. I put the tip of my scissor below, and I cut the superficial temporalis fascia down. I expose here this fat. I go then deep into this fat, and I expose the deep fascia, and I follow the deep fascia down towards the lateral rim of the orbit. This is a small video. Here you see that I cut the superficial fascia. Most important is not to dissect here in this area, because quite rapidly you can find the frontal branch. So we need to go deeper, cutting this fascia. We expose this fat, and then we cut this fat that we push anteriorly until we see here the deep fascia. The deep fascia is a bright fascia, easy to identify here. You see it here, it's really white, and you follow it anteriorly, and you get directly to the bone. This is quite an old video, but the technique is exactly the same. That's what I am doing now. So after cutting the superficial fascia, you expose the deep fascia, you follow it anteriorly, but most important, you don't work here in this area between the skin and the pancet, because this is where you find the frontal branch. Once again, on a cadaver, once you have retracted the skin flap anteriorly and you cannot retract more, instead, if you cut with a knife, you push with a sponge, and at some point it doesn't go forward anymore. So that's time to stop. That's time to incise the superficial fascia and to follow the deep fascia. You don't want to work in this area, because here you will start to see some bundle, some fascicle of the frontal branch. So then mobilization of the temporalis muscle. Mobilization of the temporalis muscle, I make an incision all around the incision of the temporalis muscle. I don't want to cut through the muscle, at least the minimum, because everything that is behind the lines that transect the muscle is dead tissue. So this is how I do it. I really take the entire temporalis muscle with me, because I want to preserve all the fibers. And then I do a retrograde dissection of the temporalis muscle fibers with this instrument, sharp angle instrument, from down up, down up. I follow the direction of the muscle fibers, but most important, I start down and I go up towards the superior temporal line, like in this little cartoon. And that's the instrument I am using. I use the sharp angle of this instrument, contact with the bone. This video is not working, but I have another one after. And then once you have done it, you have to free the muscle completely. You have to cut the deep temporalis fascia that is attached to the periostom of the lateral rim of the orbit and to the zygomatic arch. You cut this periostom here, this deep temporalis fascia. Like this, you can completely flip the muscle back and forth. Next step is the superiostal exposure of the bone. Superiostal is mandatory if you want to avoid bleedings. Whenever you're stuck to the bone, it bleeds much less, and what is bleeding can be easily stopped with bone wax. Here, be careful to the supraorbital nerve here going through his canal. And again, the superiostal dissection here at the level of the rim is the best way to preserve the periorbital. If you are not superiostal here at the level of the rim, you will not be superiostal with the periorbital, which means that you will open the periorbital. Elevation of the periorbital is something that takes time. You need to be careful. If you open the periorbital, it's a pain because the fat is coming out, and it's obscuring your line of sight. So you don't want to have some fat coming all around here, the orbit, obscuring your surgical field. You didn't do an FTOZ for that. So in order to preserve the periorbital, it's not easy. You probably all had some fat exposure, and you know it's a pain. So what I do now is that I change the position of my microscope in order to see the tip of my instrument, against the bone, and progressively I elevate the periorbital. I'm not going too deep, too fast. I progressively elevate the periorbital from the superior wall, lateral wall of the orbit. The next step is to find then the inferior orbital fissure. This is key if you want to do a one-piece FTOZ. Lateral aspect of the inferior orbital fissure, you find it deep into the temporal fossa at the undersurface of the temporalis muscle here. If you go deep, at some point, you will find a defect. This is a defect of the lateral aspect of the intraorbital fissure. On the other side of this defect, you have the orbit. So you can find the same defect moving down with a dissector along the superior wall, the lateral wall of the orbit. At some point, like this dissector, you will find a defect and you will enter the temporal fossa. Then another important keyhole structure to do is the Mccarthys keyhole. The Mccarthys keyhole is a burr hole that exposes both the periorbital and the frontal dura. How I do it? I put my dissector into the orbit because I have elevated the periorbital already, and it will give me the direction towards which I should drill to expose the periorbital. So I start with my drill. I use diamond drill, cutting coarse diamond, 4 coarse diamond to drill in the direction of my dissector. Not too low, because if you are too low here, you will have a huge burr hole to expose also the temporal dura. So you have to envision the position of the frontal dura here to make the first part of your Mccarthys keyhole not too far from the frontal dura. Once you have done this opening of the orbit, you go on the other direction to expose the temporal dura, and you will have periorbital frontal dura on this bridge of bone in between, which is the superior wall of the orbit. 2 other burr hole, 2 or 3 or 4, whatever you need to preserve the dura mater. The number of burr hole is only made to preserve the dura mater once when you elevate the bone flap. So if it's an old patient, you have to do more burr hole because the dura is stuck to the bone usually. First cut is an oblique cut at the level of the zygomatic arch. Here, posteriorly, it should be oblique. You should not leave a piece of zygoma arch because it will be very difficult to lower the temporalis muscle. Be careful, sometimes you open air cells, you have to put some bone wax. Second cut is a cut from the inferior orbital fissure that we have exposed to the orbital part of the Mccarthys keyhole. What you cut here is the lateral orbital wall from FTOZ here, inferior orbital fissure here to the orbital part of the Mccarthys keyhole. I use a B1 foot plate, but I am not using in this direction. I am putting the B1 first down and I go up. The third cut is a cut of the body of the zygoma. Here you need someone to help you to retract the skin flap. You expose here a small foramina with an artery on the nerve. It's a zygomatico-fascial foramen. It's usually 1 centimeter here from the angle between the frontal process of the zygoma and the zygomatic process of the zygoma. It's about 1 centimeter. It's important landmark because you should not cut more than this line, dotted line, because otherwise you can open the maxillary sinus. Then you do a big cut between the temporal burr hole here to the orbital rim. If you stop here at the level of the Mccarthys keyhole, it will be a 2-piece FTOZ. If you want to do 1 piece, you have to go towards the orbital rim, lateral to the supraorbital nerve. Look at your CT scan before. You don't want to open the frontal sinus in an FTOZ for a big skull-based cases. It adds risk of CSF leakage and infection. And then you take your B1 foot plate on the opposite direction towards the end of your previous cut, like this. The final cut is the cut of the orbital roof. I take some small chisel to cut the orbital roof in the same direction than the orbital rim here. And at some point it will break. The last attachment is the lesser wing of the sphenoid that you can drill a little bit and then you progressively crack it. You crack it and you progressively elevate the bone flap to have this type of exposure. So 1-piece FTOZ is a technique I just presented you. I am not doing the 2 or 3 pieces FTOZ. I am sometimes tailoring my approach, which means I am just doing a 1-piece orbito-pterional approach or pterional and zygomatic arch together, but I usually try to do 1 piece. This is other techniques, 2 pieces, taking only the zygoma out or taking here the zygoma plus the orbital rim. This is a final exposure you have after you have done your FTOZ and you have taken a little bit of bone drill, the bone of the pterion until you reach the supraorbital fissure. This is done extremely rapidly with a ronger. You can peel the periorbita, peel the dura, take a big ronger, and you take all this bone off, and you have in 5 minutes this beautiful exposure of temporal dura, frontal dura, orbit. What are the next steps? From here, and this is also the beauty of this approach, you can easily get to the clinoid process. Here is the orbitotemporal periostal fold on the clinoid here. You can peel the dura from the clinoid process. You can cut the orbitotemporal periostal fold, peel the lateral wall of the cavernous sinus a little bit to increase the exposure of the clinoid process and drill it with the proper technique. Another region you can easily access is the temporal fossa floor. Here, if you retract the temporalis muscle downward, you can do it easily because we have removed the zygoma. You peel the temporal dura a little bit from the temporal fossa floor, and you have a rapid access to the anteromedial and anterolateral triangles between V1 and V2, V2 and V3. This is really great. This is the case I showed you at the beginning of exenteration through the temporal fossa floor. Fantastic access to the sphenopalatine fossa, infratemporal fossa, and paranasal sinuses. So anteromedial in red, anterolateral in green. This is a cartoon. You can have an easy access to the sphenoid sinus, maxillary sinus, ethmoid through those corridors. This is V1, V2 corridors giving you an exposure to sphenoid sinus, posterior ethmoid here on maxillary sinus anteriorly. Anterolateral triangle, both sides of Vidian nerves that you can unroof through the pterygoid process. On the same, you have a great access to sphenoid sinus, but also to the parapharyngeal space if needed here between V2 and Vidian nerve. I show you here a video of the FTOZ. So this is a quite old video, but it's still nice for teaching. Elevation here of the skin flap. You see that I stop when I cannot push the skin flap more anteriorly. Make this incision here along the superior temporal line. Incision all along the insertion of the temporalis muscle. Usually now I do this incision after the interfacial dissection, but here I change the order. Here is the interfacial dissection, elevation of the superior fascia, and I am cutting down towards the root of the zygoma, the superficial layer. You see this fat, you cut this fat, you usually have a big vein here in the middle that you need to coagulate. Expose the deep fascia towards the lateral orbital rim, elevation of the periostom, superiostal exposure of the bone. It needs retraction. Someone needs to help you with retraction. And you cut here at some point the deep temporalis fascia attached to the zygoma and attached to the lateral orbital rim, because the next step will be elevation of the temporalis muscle. But here I have the zygomatic body, zygomatic arch down, lateral orbital rim. Elevation of the periorbita. As I said before, I am watching the tip of my instruments. I change the position. I am quite often using the microscope now to do that. It takes a little bit more time, but if you don't open the periorbita, it's a lot of time that you gain for the rest of the case. Here, retrograde dissection of the temporalis muscle. The goal is really to preserve this deep periostal layer that protects the veins, the arteries, and nerve for the temporalis muscle. They are deep to this white fascia. So if you don't preserve this fascia, you will injure those nerve and arteries, and you will have for sure temporalis muscle atrophy. Is it an issue? Cosmetically, it's not very nice. And most likely, patient will complain the year after of TMJ pain. So it's important to preserve the temporalis muscle. We use it every day to eat, to speak, so it's an important muscle. Here is a detachment from the zygomatic arch after cutting the deep temporalis fascia. So now the muscle is completely detached from the bone, but it's quite intact. It's between two aponevroses, and the bundles of arteries, nerve are intact. Mccarthys keyhole, I drill in the direction of my dissector into the orbit. And once I have the orbit, I drill in the opposite direction towards the frontal dura. I have a bridge of bone in between, that's the orbital roof. Temporal burr hole, frontal burr hole, nothing special about it. Again, the more burr hole you do, the less risk you will have to injure the dura. And it's always good for closure. First cut is a zygomatic cut, as posterior as possible, oblique cut. You want to take all the zygoma out to be able to retract the temporalis muscle. The cut of the lateral wall of the orbit, cut of the body of the zygoma now. Someone is helping me retracting the skin flap, and I use this retractor as a roller to do the cut. I don't finish it with this drill, I finish it with a chisel. Then frontotemporal bone cut, I end this cut at the supraorbital rim lateral to the frontal supraorbital nerve. Here is cut in the opposite side. And now a cut of the sphenoid ridge. Final cut is the orbital roof cut. And here is the bone flap removal. Takes a little bit of time, and you have to cut the insertion here of the masseter muscle that are attached to the posterior aspect of the zygoma. I show you two cases. This was a giant aneurysm pushing up the chiasma. It was a clinoidal segment aneurysm and also carotido-ophthalmic. This patient was blind on the other side because of the small stroke, because of thrombosis. So you had only one eye, and the neuroradiologists were scared to do an endovascular treatment of this aneurysm, because if it grows a little bit, patient would have been blind. So we decided to do surgery on it, FTOZ, to have a wide exposure of this area of the skull base where the aneurysm is. And I also did a bypass, protective bypass for this patient. STA, MCA bypass, it was enough, considered enough for this patient. We thought it didn't need a high flow bypass. This is the FTOZ approach. Incision all around the muscle, retrograde dissection of the temporalis muscle, same than before. Here you see that I am looking at the tip of my dissector for the elevation of the periorbita. That's the only way to preserve the periorbita. Mccarthys keyhole here, with one part exposing periorbita, the other exposing frontal dura. This is the cut of the lateral orbital rim. This is now, once the bone flap is removed, drilling off the pterion. I am peeling here the lateral wall of the cavernous sinus to expose here the clinoid process. I did an optic nerve unroofing, optic canal unroofing. I wanted to decompress the optic nerve first before manipulating the aneurysm. And I wanted also to have an exposure to the clinoidal segment of the ICA. This is clinoidal segment of the ICA proximal to the aneurysm. I tried to put a clip here, but it was not possible because it was too big. This is proximal ring here, and it was too much, too big still. It was the beginning of the aneurysm. So what I did, I will show you in a minute. I went to the petrous ICA. Here is the exposure of the aneurysm, exposure of the optic nerve. You can see something very interesting now is how this is the aneurysm, yes, the tip of the aneurysm with the MCA coming out of this, or coming out of it. And here it's really the tip of the aneurysm. I wanted to be sure that the PCOM on anterior choroidal was exposed. And here I just cut the falciform ligament. You see the print of the falciform ligament did on the optic nerve. I am now doing the bypass, fish mouth of the STA, classic bypass here, because the treatment of the aneurysm was trapping, clip proximal, clip distal. So you need to bring some flow in this patient. 2 extremity stitches first, and then I am not doing running suture for STA, MCA. I'm doing separated stitches. Okay. Anterior wall, posterior wall. This is a bypass. Everything is fine. I am going now subtemporal to have proximal control. Very easy access to the subtemporal area because of the FTOZ. You see that I have a fantastic window given by the retraction of the temporalis muscle. I am drilling Glasscock triangle to expose the carotid artery petrous ICA. So I could not put my clip at the level of the clinoidal segment. I put it at the level of the petrous ICA. The only issue was that the aneurysm postop was still filing a little bit with the Vidian artery, but very rapidly thrombosed and completely shrink. So this is almost the end of the surgery. I make sure that the bypass is playing its role after putting the clip on the petrous ICA. I'm quite happy with the flow, and I am putting now the distal clip, making sure that the anterior choroidal artery is safe here, as well as the posterior communicating artery. So for a case like this, where you need access to multiple areas of the skull base, FTOZ approach was great. Final case is this one. I think I will skip the video because it's about the same. Big clinoidal meningioma. To me, if you want to avoid retraction of the brain, have access to the origin of the meningioma, which is the clinoid process, rapidly without retraction. It's a perfect approach. This case was not so easy because the carotid artery was inside, as you can see here, and it's definitely a challenge to preserve carotid and also its branches. Interfacial dissection, but we saw that already, so I go fast. Okay, final words about complication, risk of having issues. Yes, there is, because you see that the soft tissue dissection is extensive. Risk of frontal palsy, temporal muscle atrophy, CSF leakage if you open frontal sinus, maxillary sinus, air cells on the zygomatic root. TMG disorder, if you dissect too much posteriorly, you open the joint, or because of temporalis muscle atrophy. Subcutaneous hematoma, you see on this picture, the temporalis muscle atrophy, and infection. It's usually long cases, so you have to be extremely careful with the risk of infection. That's temporalis muscle atrophy here, not so nice as you can see it. Thank you to my team and to my fellows helping me with all those dissection and work. Thank you very much.
Thank you so much, Sébastien. Very impressive talk as usual. You highlight all the benefits of this approach, different angle of attacks, shorter corridor. You speak also about the complications. Maybe one just question, could you say a few words about the more tailor-made approach, when you by sample just remove the orbital rim, or when you just remove the zygoma arch? What's your philosophy about that?
I definitely tailor according to what I need. And if you learn to do the one-piece FTOZ approach, it's not to do the one-piece FTOZ approach every time. If you know how to do the one-piece FTOZ approach, it means that you can really tailor as you want. You know how to do an interfacial, you know how to do retrograde dissection, you know how to expose inferior orbital fissure, you know how to do a Mccarthys keyhole, so you can do whatever you want. Once the bone is exposed, the bony removal, the bone removal depends on what you need. And sometimes, yesterday I did a craniopharyngioma, I did the exposure like an FTOZ, but I didn't expose the zygoma, and I did orbito-pterional. Mccarthys keyhole, cut here the lateral rim of the orbit, and I took all this out. So yes, those techniques, the most important is the soft tissue dissection. If you know how to do the soft tissue dissection, then you can do the bony work tailored to the pathology. The size of the bone flap, sometimes you need a big bone flap because you want to open the sigmoid fissure. But sometimes I do an FTOZ with just a very small exposure of the frontal dura, temporal dura. It depends really of what you need. And this takes time before the surgery to plan what you will need.
It was a way for me to introduce your works that I know that you made with a transpalpebral approach, transorbital approach, endoscopic assisted to some region. It was a way for me to allow you to comment about that. I know your work, but maybe you can take a few minutes to explain what you are doing now to extend your approach to the skull base through very limited corridors.
You're talking about the transorbital approach.
Yes.
Transorbital approach, we are working on this, and but the technique is a little bit different. It's not an eyelid approach, because the eyelid approach, I believe there may be some cosmetic issues, and as a neurosurgeon, I'm not so comfortable cutting the eyelid. But what I know very well is the incision of the eyebrow, because I am doing a good number of keyhole. So I do an eyebrow incision, and then I just do a crescent shape craniotomy just of the rim itself. I am not exposing the frontal dura. I am just cutting the rim with the B1 foot plate going this way, just a crescent shape. And instead of having a trajectory like this, transorbital endoscopic, I have a trajectory like this, using the microscope and the endoscope. So we have been using it. I will do a case next week, I think, of cavernous sinus meningioma lateral wall with this technique, because it gives you a fantastic way to this area without a need for temporal lobe retraction. And again, all what we do as a skull-based surgeon is to take out some deep-seated pathology and to protect the brain. The first goal is to protect the brain, not to expose the brain if it's not needed, not to retract if you have another way. That's the only goal of skull-based surgeon. If you don't do that, you're not a skull-based surgeon.
Definitely. That will be the final word of this webinar, I think.
I like my conclusion. I'm going to write it.
Yes. Nothing else to say from my side.
It's time to stop talking, because I'm listening to myself too much now.
It's recorded, you know, you can even repeat it.
Okay, Michael,
So-
thank you so much for your work and an investment into those webinars, because
It was a pleasure, but
it's tough to organize and it's always great.
it's always great to have you with us, Stefan and Sebastian. I think when I see the comment in the box, it's a very wonderful webinar that you allow us to attend. So thank you also to attend, and to you, Sebastian and Stefan, to give us such wonderful talks. It will be my pleasure to see you again in a few weeks. The next webinar, I think, will be organized in 4 weeks on another skill-based topic. I think it will be anterior petrosectomy. So it will be my pleasure to see you at that time, and all of you. I see you are still many to attend this webinar. So see you soon. See you next time.
See you soon. See you
Sebastian,
soon.
I give you a phone call right now.
I have to go back to the OR. I call you after. Okay.
Okay, that's great.
Bye bye. Bye bye. Bye bye.
Have a good evening.
Bye bye.